IBS present? Well, our time is fast going, and one of the major things I want to talk about today is dysphagia. If I have not talked about it, I won't be so happy. So, dysphagia can come in your exam in different ways. And today, what I just want to do, I know all of you know all these topics I'm about to talk about. If you don't know these topics, they will either be treated in another topic or they have already been treated. Let me say that again. They will either be treated in another topic or they have already been treated. We have treated quite a lot of things. There are a lot of points that you should know already. I'm not talking about the drills. I'm even talking about the classes. We've done quite a lot of stuff. In some classes, I've moved things to the drill because there were just too many points. When we're doing endocrinology, 500 points to know. In the class, we did about 400 of them. I moved about 100 to the drills. So a candidate will tell me they don't know the 400 points. It's self-harm. Go and know the points. I spent time on diabetes. I know I spent time on diabetes. Even with the time I spent, I couldn't cover it all. I had to stop. I had to move the management of type 1 diabetes to the drills. Even the management of type 2 diabetes, insulin glargine determined, I put it as low yield. I moved it to the drills. It comes out. Diabetes is an area that anything can come out. High yield, low yield can come out. I specifically spent time on thyroid. How do you now tell me that the picture of a patient with autoimmune thyroid disease came out? You don't know it. How do you tell me that FMAP came out? Follicular anaplastic cancers, papillary came out? You don't know it. You have done a disservice to us because I explained it. I told you Riedl's disease is the thyroid. The patient with the thyroid mass that is as hard as stone. You touch the mass, it's very fibrous, it's very hard. That's Riedl's. How do you fail it in the exam? I tried to differentiate all of the thyroid. I told you that hyperthyroidism will be the name, but secondary hypothyroidism will be the name for the other one. I tried to explain these things. I tried to break them down. We looked at subclinical hypothyroidism management and we differentiated it from subclinical hyperthyroidism. I painted pictures. I told you about postpartum thyroiditis. How you now be in this class and you don't know it yet? When you want to know it, is it a week to the exam? A week to the exam, there are too many things to know. It is now to know it. That management, this is the time to know it. We then went into medications. I told you that there are certain medications, even yesterday in the mock, we still saw it. Lithium, it causes thyroid disease. The one that causes both hyper and hypo, we did it again yesterday to show that it's super high yield, amiodarone. I told you all the sex hormones, they are causes of hypo or hyperthyroidism respectively. Testosterone is a cause. Estrogen is a cause. Progesterone is a cause. Why do you fail these things in the exam? Well, dysphagia is high yield, and I just thought I should take some time just to paint the picture because doing the topic is useless. Candidates will go, still see that topic and fail it. So my friends, how do you see new onset dysphagia and weight loss and you are still thinking it's a cancer? Please, missing cancers are very dangerous. In real life, the GMC will come knocking at your door because the patient will not rest until they bring the doctor to book. Your medical defense union MDDUS will pay out a large sum. I can assure you. Once they see that it's a missed cancer, they see that the patient had red flag like projectile vomiting and weight loss, and the patient had new onset dysphagia. They don't argue. They say, doctor, you are wrong, but because we are going to protect you, we'll pay out £1 million. That's what they will do. They will not argue. They will not even go to court. They will go beg the patient, can we pay you £500,000? The patient will say, no, I'm going to court. You say, please, let's settle out of court. Let us pay £800,000. But the patient will say, no. So you knew I had cancer. You waited 6 months to diagnose me. I've been coming every day. In my note, you are writing weight loss. In my note, you are writing projectile vomiting. In my note, you are writing this dysphagia just started, and you didn't diagnose that I had esophageal cancer. What are you doing? At the end of the day, they will settle for £1 million. They have to pay out. And these are things, I tell you, this course, apart from helping you for your AKT, is real life as well. Don't fall into the trouble of GMC. It's not nice. It's not good. You're going to be a new GP in a year. You're going to be a new GP in 2 years. These are the places. These are the places where you need these teachings to remember that weight loss is always a red flag. Find out if a patient is losing weight. What else? Weight loss and new onset cough, chest cancer. Weight loss and hematuria, bladder cancer. Weight loss and diarrhea, colorectal cancer. Weight loss and confusion, there's a cancer in the brain. The patient, there's a problem there. It's a cancer. Weight loss and difficult to swallow is esophageal cancer. So weight loss, new onset diabetes in a 63-year-old is pancreatic cancer. So you need to know weight loss and bone pain. You should know these things, my friends. Weight loss is a red flag everywhere. We just finished IBS. I told you weight loss with IBS symptom is 2 week weight. So weight loss everywhere. Think before you tell the patient, well, let's do watch and wait. No, ask all the right questions. Is a red flag that people shouldn't miss. So today I bring a picture, and this picture is a 61-year-old who has come to you, says, doctor, I'm having difficulty swallowing. You say, okay, what else? The patient says nothing else. So are you sure you've not lost weight? He said, oh, thank you, doctor, for reminding me. I've not been checking my weight, but my clothes are no longer my size. They look bigger than me. My friends, 2 week weight, esophageal cancer. 2 week weight to gastro is what you need, especially when the patient starts to eat and regurgitate. Food is no longer passing. It's usually at the lower, we call it less. Lower esophageal sphincter is the problem. There's a cancer developing there, lower to third. Squamous cell carcinoma, you need to know what is in the upper 1/3 and lower to third. This patient has a cancer around the esophageal sphincter, and that's why they are regurgitating. This patient has a cancer that is blocking food passage, and that's why they are having vomiting. Sometimes it's not projectile, it's effortless. Effortless vomiting is to esophageal cancer, as projectile vomiting is to raised intracranial pressure. Don't fail it. And by the way, if you are thinking we have not done papilloedema, we have completed papilloedema under ophthalmology. I told you the difference between papilloedema and glaucoma. One is raised intracranial pressure, the other one is raised intraocular pressure. I told you what the tonometry will find. 22 to 28 in glaucoma. I overstressed glaucoma. That day, I begged you guys. I gave you different pictures. When you people were tired, before you people went, I begged you again and came back to glaucoma and papilloedema. I repeated them. I told you the other things that can cause papilloedema in the AKT. I repeated it. I told you that seeing papilloedema is red flag. I told you for that guy that has papilloedema, don't send to the medical ward. I told you where to send to. Ophthalmology ward. You need to save their eyes. I begged you guys to store this. So I'm begging you again. That question can be your question 1. Can be on papilloedema, especially if the patient is vomiting. Especially if the patient is a young girl on combined oral contraceptive. What's that? Idiopathic intracranial hypertension. Pseudotumor cerebri, that's the other name in the AKT. Is that girl on combined oral contraceptive? What do you need to do? Lumbar puncture is not a definitive management. It's symptomatic. Propanolol will help that girl. Stopping COCP will help that girl. You just basically need to know all the causes of headaches in the AKT. But let's go back to this patient that has got dysphagia. Dysphagia that is new in a smoker is still esophageal cancer. How do you now fail the question when they say the dysphagia is new, the patient is a smoker with a history of Barrett esophagus? What are you doing? Past medical history, Barrett esophagus, smoking and dysphagia in that patient is esophageal cancer. I beg you, don't fail it in real life, don't fail it in the AKT. In the AKT, it will cost you an exam. In real life, it will cost you your license. Okay, let's move on. When you are seeing a patient with new onset dysphagia, patient says, doctor, I cannot swallow. This patient is in their 30s. But you look all over the note, you are seeing that they've been coming with reflux symptoms. Well, that's fine. You have been treating with omeprazole, you've done H. pylori, you've done lifestyle, you've told them not to eat fatty food or reduce Chinese food. The patient has done that. You've made sure they are not on ibuprofen. The patient has done that. You've told the patient to eat small meals around the day. Patient is now eating 5 times a day and they are very small, small meals. You say don't take alcohol. The patient has done that. The patient says they never smoke. The patient is losing weight. The patient say, what else do you want? Doctor, all the things you've told me to do, I'm doing it. I'm even on high, I'm on omeprazole that you guys breathe. I've done endoscopy before. Everything was fine. Why is it that now I cannot swallow? My friends, there's a difference between faucet and a patient having dysphagia. Don't fail the question, both in real life and in the AKT. Faucet is a feeling of something in the throat. It's not a red flag. It may not be a red flag depending on what comes with it. But new onset dysphagia in a patient known to have reflux or heartburn is a 2-week wait. Don't fail the question. That is esophagitis, but you need to rule out other causes. That patient needs endoscopy. What am I talking about? Alarm. Is the patient over 60 and has alarm sign and you are laughing with the patient? You are saying, okay, oh, have you always been in the area? That's not your business. What your business is does this patient have anorexia? Does this patient have weight loss? Is this patient having melena? If the patient has any of those alarm signs, what you need to do if the patient is above the age is to refer on a 2-week wait. New onset dysphagia in this patient that has always had heartburn for 8 years, and you are saying, well, your heartburn is probably because of the reflux. Let's see whether to go. No, he needs an endoscopy, 2-week wait. Don't fail the question. In real life and in the AKT, it is new onset dysphagia. New things are a red flag. Yesterday, we saw new murmur in a patient. It is infective endocarditis until proven otherwise. New is a clincher, my friends. So here, please look at the new. New dysphagia, ongoing heartburn or history of heartburn, 2-week wait. It's esophagitis, but think of a 2-week wait in this patient. Well, can I paint another picture of a middle-aged man? This man has been using, he's got asthma. Well, I know some of you have already echoed the question and the answer. If you've echoed it, well done. You've created a mental picture. Please, as I'm saying these things, before I finish, just quickly echo the answer out. If you're finding yourself struggling with echoing the answer out, it means you're having a problem with interpretation. It means you are still having a problem creating a mental picture. The AKT may be slightly difficult. So you are seeing new onset dysphagia with someone using inhaled steroids, or you are seeing new onset dysphagia, they don't mention inhaled steroid, they say it's an asthmatic on treatment. They've hidden it from you. What are you doing? Steroids and new onset dysphagia, if you start to see that patient has candidiasis, what type of candidiasis? Esophageal candidiasis. Don't fail it in the AKT. Where else can esophageal candidiasis present in your exam? Dysphagia in HIV is esophageal candidiasis until proven otherwise. By the way, HIV can hit you anyway. HIV and diarrhea, cryptosporidium. HIV and diarrhea, cryptosporidium is the cause. HIV, the patient is a bit having some issues. The patient is having headache. The patient is a bit disoriented. Toxoplasmosis gondii, ring enhancing lesion in the brain. Well, patients say, I can't see very well. You look into the eyes, you are seeing some stuff in the eye. That's cytomegalovirus, my friend. CMV retinitis is the cause. What are you thinking? HIV with rapid weight loss is no longer HIV. Please do the CD4 count. Think AIDS, progressive disease. HIV and skin lesion. What's that skin lesion? Is raised? Is that, what are you thinking? Is purplish? Is whatever color? It can be Kaposi sarcoma. Choose the answer, move on. HIV can affect anything. HIV and cough, TB. My friends, how do you fail HIV and cough? How do you even fail anything about tuberculosis in the exam? When every day we talk about tuberculosis, there must be some. In fact, I'm still going to talk about tuberculosis very soon. When I'm going to vitamins deficiency, I have to talk about tuberculosis. Isoniazid is a reason for prescribing vitamin B6 pyridoxine. Why? Peripheral neuropathy caused by isoniazid. So you can see that the AKT is interwoven. No topic is distinct from another topic. They are all friends. Let's go back to the topic. I planned that today, maximum 9:30, I'm going to release you and I'm going to try and do that. I know time is far gone. I can't see the time now, but I'm going to just be streamlined. I'm going to go on this dysphagia because you need to know it. So you've seen that picture of a patient that is having difficulty swallowing liquid and solid at the same time from onset. If you've echoed achalasia, good for you. But if you have not said achalasia, you need to start to understand how to create mental picture. Achalasia in the exam, botulinum toxin. Botulinum toxin is a treatment for achalasia. What do I mean? BASH. If you are here, you don't know BASH, please, it means that, and you're writing the AKT, it means that you've not been attending the drills. We cannot help you. BASH is blepharospasm. A in BASH is achalasia. Spasmodic torticollis is one of the S. The H, one of them is hemiphageal spasm. The BASH is BASSH. Please join the drills in the afternoon. You would learn BASH. Okay, so you've known that if a patient has a difficulty swallowing solid and liquid, is achalasia. Please don't fail it in the exam. Try not to fail it in the exam. Well, I've seen this patient. The patient is having bad breath. Bad breath. I go closer to examine the patient. There's a midline lump. Dysphagia with a midline lump and halitosis. The patient is probably regurgitating food back up. The food tastes really bad and smell really bad. How do you fail it? If you don't see pharyngeal pouch in your exam, Zenker's diverticulum is the correct answer. Pharyngeal pouch or Zenker's diverticulum, correct answer. Pharyngeal pouch, Zenker's diverticulum, correct answer. Don't fail it in the AKT. So I've told you how pharyngeal pouch will come. There's halitosis. There's a pouch that gargles. This patient, the pouch stores food. As part of the food is going down, some of them are entering the pouch. If you press on it, the patient sometimes may even regurgitate. Old food, foul-smelling food. This is pharyngeal pouch. Zenker's diverticulum. Don't fail it in the AKT, I beg. Well, how do you see? Let me paint you a picture of a middle-aged patient in their 40s. They're having new onset dysphagia and what we call calcinosis. Don't fail it, is systemic sclerosis. They give you that same picture. They say this patient has dysphagia. He has Raynaud's phenomenon. What are you thinking? It's systemic sclerosis. If the patient cannot swallow and they're having what we call sclerodactyly, it is still systemic sclerosis. How about this same patient has dysphagia and telangiectasia? What are you doing? It is still systemic sclerosis. By the way, telangiectasia, BCC. Telangiectasia, acne rosacea. Telangiectasia is the patient with HN's PCC. Lynch syndrome. Someone is asking, how do I remember these things? Put pictures together. Whenever I see telangiectasia, 6 pictures have just come to my head because I just mentioned telangiectasia. When 6 picture comes to your head, you know you are ready for the AKT. When no picture comes to your head, don't write the AKT, my friends. Postpone it. That's the only reason why I'll tell you not to write the AKT. You are reading question 1, no picture comes to your head. You struggle, you spend 3 minutes on it. You read question 2, no picture. When you read 10 questions and no picture is coming to your head, postpone the AKT. You are not ready, my friend. If you read it, only 1 picture comes to your head, you need to work hard. I beg you. You are not working hard enough. Some candidates are writing their exam in January, some are writing April next year. The picture has to be in your head now if you want to write in April. Anybody that is writing in October and it's just now that pictures are just starting to come to your head small, you will struggle because you need a minimum of 5-6 pictures in your head so that you can keep cutting them down. You need all the pictures in your head about that thing. Telangiectasia, every single picture should come to your head. It's you that now reads the next line and sees that telangiectasia and a swelling, what we call a lesion on the nose, is not any other thing but either BCC. Let me see if it's something else. Can it be SCC? No. SCC is the satellite lesion. Where else do you see satellite lesion? Candidiasis. You see, your head should be working. Your head should be connecting dots. Your head, you shouldn't be in a group where everybody are arguing, they're arguing things up and down. What you should be arguing are clinchers. Where do we see satellite lesion? if you can mention 10 places you see satellite lesion. That's why we do drills. I ask you what are 10 causes of telangiectasia. The only reason I'm asking you is to build a mental picture. And if I don't explain what we are doing in the Easy Learn community, then you don't understand how it works. We tell you, we build a mental picture so that when you see satellite lesions, 6 picture comes to your head. As you read on and see that the satellite lesions are in the groin area, you know that that satellite lesion is likely not an SCC, it's likely candidiasis. As you read on, you now focus on other clinchers of candidiasis. You narrow down, you pick the answer. How do you feel it? How do you feel it? Same thing with telangiectasia. How do you feel it? Same thing with everything. How do you feel them? So this is the picture I want you to see. And quite a lot of people did not apply them in the mock. Quite a lot of people knew some of those things at their fingertips, which was good. But there were questions where they couldn't pick up the clinchers and use it to get the answer. And this is what we teach. Use the clinchers, get your answer. So you've seen systemic sclerosis can come in 5 different ways. The CRE syndrome, CRE, the E is the esophageal dysmotility. That is the new onset. That is the dysphagia. But when it's new onset, please think about, if you come to any of the other things, think about systemic sclerosis. By the way, the antibody in systemic sclerosis is anti-SCL antibodies. Don't fail it in the exam. If it is local sclerosis, if it's diffused, what we call local sclerosis is ACAB, anti-centromere antibodies. These things, I've known them since my ST1. I've never forgotten. How do I remember? I use ACAB. Use something to remember something, my friends. ACAB, anti-centromere antibody, is to limited sclerosis, as anti-SCL antibody is to systemic sclerosis. I further remember by saying ACAB. I need a cab if I want to go around in a local area, limited. I need a taxi, a cab. But if I need to go systemically, from the liver to the kidneys to the brain, I need a flight. The name of that flight is anti-SCL antibodies. How do you fail these things when you have related them to something that you will never forget? My friends, you don't need to use our acronyms in Easy Learn. I asked a candidate, the candidate says, oh, I don't remember urticaria causes with panels. I remember urticaria causes with another acronym. That's fine. Nobody wants you to use a particular acronym, but know them. If you don't have one, if you have another way of remembering, is good. But if you don't have a way of remembering and you know you will crash under pressure, you know you will shrink under pressure of AKT, then what are you doing? Learn a remembrance aid. Get a mnemonic, especially if it's a difficult topic that is difficult to remember, understand. Don't cram. Use a mnemonic, because if you start to cram too many things, you run into trouble. Okay, you've seen anxiety in a patient with dysphagia and you are still thinking, is globus hystericus until proven otherwise? Globus hystericus is anxiety plus dysphagia in a patient. Globus hystericus, new onset dysphagia plus anxiety, that is globus hystericus. I give you a picture of a patient who is having eye problems. The patient comes and say, doctor, I cannot swallow very well again. When I'm swallowing, I'm having problems swallowing. You say, okay, is it odinophagia? He says, no, it describes dysphagia. You say, what else? You say, doctor, my eyes. He explains something. You say, oh, that is ptosis. By the way, if you don't know Horner syndrome, what are you doing? Know the difference between Horner syndrome, Aji-Robinson's pupils. You need to know all of them. Holmes Adil pupils, all the relative afferent pupillary defect, RAPD. You need to know them. I talked about them when we're doing ophthalmology. Go to town with them. Which one is sinister? Aji-Robinson. Which one is the nice one? Home Adil. How did I remember? Home. Home Adil is that homely woman that has lost her ankle reflex. You try to do knee jerk, it doesn't come up. Why? Home Adil. But it's not harmful. Why do I say Aji Robinson is harmful? Syphilis, diabetes, they are all causes of Aji Robinson's. How do you feel it when you have coded everything in your head? You have so many things in your head. In my head now, I have up to 10,000 points, but I can always bring them out easily when needed. Why can I bring them? I've associated them with something. And I've told you, for you to go into the AKT, you need a minimum of 5,000 points. Not 5,000 points in a specific area, but you need at least, as you are going around, you are needing about 300 points per area. Some areas like endo, you need 500 points minimum. Areas like you go to cardio, you need about 400 to 500 points. But when you go into gynae, you need 800 points or 900 points to pass the exam. Pediatrics, you need about 1,000 points, close to pass the exam. Hematology, you need 200 points. Once you have all these points, you go to the exam, you are super equipped. Someone is trying to ask me, what are these points? Those are your drills. Someone is asking me, what are these points? Those are the mock things. Some of the times you see a question in the mock, the answer in the mock, rather than being the answer to the question, we know some of you will get the question and the answer correctly. So rather than being the answer to the explanation is just one line. There's something else related to that topic we have put there. It is a point that you have to know. It's a point, and we are using all different ways to give you this point, because we cannot give all the points in the teaching. We cannot give all the points in the drills. Some of the points will come in the mock. Everything in the revision is a revision of all the points we have been doing. There are no new points 2 weeks to the exam. Any point we have not done 2 weeks to the exam, we don't give you again. It means it's probably not high yield. Some of the high yield points now, by now, you would have heard them 8 times, 10 times. Some people have heard some people are tired of hearing some things because we said it about 15 times. Why? They are likely to pop their head in your exam. So can I beg you to be good? How do you become good? Have points at your fingertips. Can you see that even your notes, we have put them as points? We recognize that the point system is the easiest way to get 90 in the AKT. It's not notes. Reading notes is jargons. Removing the most important thing from the notes is the point. That's how you should study, my friends. Well, I've tried not to put so much on the screen. Everything I've been saying there, you can see them on your screen now. You can see that heartburn plus dysphagia esophagitis. If you see HIV and dysphagia esophageal candidiasis, and if it's steroids in a patient with asthma, please think esophageal candidiasis. Look at that Barrett esophagus and smoking, esophageal candidiasis. And if you see achalasia and you don't know it, please, what are you doing? You need to know achalasia. Can I continue? A patient says, doctor, I've just come from treatment of my cancer. But doctor, now I'm having difficulty swallowing. Radiotherapy is the cause of the patient's dysphagia, my friends. What are you thinking about? You need 3 seconds. There are some you need 10 seconds, some you need 5 seconds, some you need 20 seconds, some you need 1 minute. The ones you need 1 minute should be only 10 questions in the exam. In fact, for me, I say reserve the 1 minute for a few statistics questions. Meanwhile, many of the statistics questions, you actually need 30 seconds. But if anything is going to take your time, maybe you need to understand a graph. Reserve 1 minute for a few statistics questions. How many statistics questions is on your exam? RCGP said there are 20. Maximum 20. It means that if you have 20 minutes, you can even use 1 minute for all your statistics questions. But for your clinicals, that is my concentration here. For your clinicals, I beg you, don't spend up to 40 seconds. Use less than 30 seconds to clinch it. A candidate says, oh doctor, this AKT, I am slow. You are slow because you are over reading the question. You are slow because you are not getting a picture in your head. You are slow because you don't understand clinchers and cliches of that question. That's why you are wasting time on it. You're missing the answer because you don't have the clinchers. And each time I teach the clinchers. All these things you are seeing are the clinchers. The 2 things you need in that question is heartburn and dysphagia. The 2 things you need in that question is anxiety and dysphagia. The 2 things you need in that question is HIV and dysphagia. The 2 things you need in that question is steroids and dysphagia. The 2 things you need in that question is dysphagia to solid and liquids with new onset dysphagia. The 2 things you need in that question is Barrett esophagus and smoking. The 2 things you need in that question is weight loss and vomiting. The 2 things you need in that question is missing dentures in an elderly patient. What has happened? Foreign body. Their dentures is in their throat and it's causing them discomfort. They are having dysphagia. It's caused some inflammation there. They're having dysphagia. It's foreign body causing their dysphagia. Can I show you a picture of a patient with dysphagia, iron deficiency anemia, and what we call esophageal web? If you've never heard of it, I announce to you today, Plummer-Vinson syndrome is a cause of dysphagia. Don't fail it in the exam. Can I repeat that again? It's one that many candidates have not heard of. If you've not heard of it, we're doing it in the drills. Some of the candidates knew the other ones, but when I came to Plummer-Vinson, it was strange. Plummer-Vinson syndrome in the AKT is a patient who you will see HB will be low. I know someone is waiting for iron deficiency anemia in the question. You won't see it. And I deliberately tell you how you will see the question. They will put a biochemical picture. Do you know the AKT wants to use one stone to kill two birds? What do I mean? They want to see whether you can interpret biochemical pictures, because that's one of your jobs. That's why I keep saying that rather than them interpreting for you, you won't see it. They'll put a biochemical picture. You interpret yourself. Yesterday in the mock, there were quite a lot of biochemical picture, low potassium. Some people say, oh, I forgot it's Addison's. Addison's adds potassium. But you won't see that potassium, you won't see hyperkalemia there. You will just see potassium of 2.8. Then you know that it's low. If you see greater than 5.5, you know what it is. Potassium greater than 5, be careful with ACE inhibitors, my friends. Be careful with ACE inhibitors. Okay, you've seen this patient. This patient is having esophageal web, iron deficiency anemia picture, new onset dysphagia, Plummer-Vinson syndrome. Because of time, I'll stop here. We'll go to another topic, but I just want to tell you that dysphagia is high yield. Dysphagia is high yield. And looking at the AKT, you can see anything in dysphagia, anything at all, but know the red flags, know the common causes, know everything that can cause dysphagia in the AKT. It will be counterproductive that we spend so much time playing around dysphagia and you don't get the answer. You can say I could have done this, all these things we have done here is 10 topics. Radiotherapy is a topic. I could have discussed foreign body. It's a topic. Sometimes I do that. I just discuss foreign body, and there you see a lot of points. Global historicus is a topic. Plummer-Vinson syndrome is a topic, but you don't need Plummer-Vinson's anywhere. The only place where you need Plummer-Vinson's is when we are talking about causes of iron deficiency anemia, and when we are talking about dysphagia. And how do you need it? This is how you need it. In the question, is a patient that has iron deficiency anemia. At the end of the question, they say he recently is having difficulty swallowing. So they can bring it under talking about iron deficiency anemia. When they are bringing under, I just told you, whenever you hear iron, think of Plummer-Vinson. Whenever you hear iron, think of hemochromatosis. Whenever you hear iron, think of iron deficiency anemia. Please, causes of iron deficiency anemia. If you are in this class, you don't know 50, please go and know 50. Worms are a cause of iron deficiency anemia. I keep saying it. Schistosoma hematubium, they will be releasing blood from the bladder. Bladder cancer is a cause of iron deficiency anemia. They are losing blood, my friends. Ankylostoma duodenale is the name of the old hookworm. Don't fail it in the exam. The new hookworm, something Westermanni, you need to know them. The ones that are the long fluke, you need to know them. The tapeworm, Tinea solium, you need to know them. You need to even know the broadworm. How come you are going for the AKT, you cannot say the answer when they ask you about threadworm in a child? Investigation, use that tape. Use that tape. It's not, don't go and start taking stool samples, sending to the lab. You're in primary care. Someone says, oh, I need to, the problem with me, I've found out from the mock is that I need to think in the line of primary care. You're a GP. Take a tape and put it on the anus of the child and try to get the eggs. Try to get the eggs. You see it overnight. Give mebendazole, my friends. Threadworm, mebendazole. By the way, if you are thinking about that, also think of head lice, nits. You see those things in the hair, nits. Know when to treat. Do you treat the whole household? And what do you treat with? You need to know first line, second line, third line, fourth line. Some people only know wet combing. My friends, they can change it. Some people only know malathion. My friends, they can change it. There are other treatments. There are 3 other treatments you need to know. They are all insecticides, my friend. That's when you now have to go to scabies. Make sure that they wash all their clothing. Who do you treat? Is it the whole family or is it only the person? We've done some of these things. We've done all of these things. We've either done it during the period, our break period, what we call the charity course, or we've done them in dermatology. Scabies, know which one is permethrin, which one is 0.5%, which one is 5%. And how do you apply it? Which one is 8 hourly, which one is 12 hourly? These things will creep up in your exam. You will say we've been taught in Easy Learn, but I don't know it. How do you feel? How do you feel not knowing things that we've done again and again? I'm repeating it because a candidate is planning to fail it, but we don't want you to fail. We beg you, go and revise it today. The more you revise it, the more you tell AKT, I'm not going to fail that question. So you can see iron deficiency anemia is taking you places. Why don't you settle down and use iron deficiency anemia? Study 50 topics. Fit test, 2-week wait, colorectal cancer, iron deficiency anemia. Iron deficiency anemia is one of the criteria to diagnose colorectal cancer. So how do you fail these things? How do you fail these things? And someone is here saying, oh, iron deficiency anemia there? As if we have not done it. It's WARIC. WARIC, that's the acronym. I've gone around the class, I've gone around the drills, I keep asking what is WARIC. Everybody says, oh, 40 people, sometimes people will play with it on the day we talk about it, 40, 50, 60 WARIC. But the next class you cannot remember, don't do that. 40 is to WA, weight loss, anorexia. 50 is to iron deficiency, is to rectal bleeding, that's the R in WARIC. And 60 is to iron deficiency anemia and change in bowel habit. That is 40, 50, 60 WARIC. That is 2-week wait colorectal cancer guidelines. How do you go to the guideline and start cramming it? You forget. If you don't find a way to code the guidelines, and don't go and read all the guidelines, read the important part of the guideline. I just brought it out because that's the most important. 40, 50, 60 WARIC. That's it. That's a cause of iron deficiency anemia. Someone says, okay, you have just mentioned 6 causes of iron deficiency anemia. So I don't think we can get up to 50. I know if you get to 10, you stop. All your renal conditions, what are you thinking? CKD is a cause of hematuria sometimes. So that can cause anemia. How does CKD cause anemia? Many ways. Erythropoietin is no longer produced, my friends. Look at all the ways it causes anemia. One of them is iatrogenic. The doctor is always taking blood from this patient for tests. They will have anemia. So there are 4 ways in which CKD can cause anemia. Why don't you go back and just look at CKD? By the way, whenever you're talking about CKD, if secondary hyperparathyroidism has not popped in your head, I wonder what you are doing. Secondary hyperparathyroidism is CKD. If it hasn't popped into your head, what are you doing? Secondary hyperparathyroidism, vitamin D will be low. I wonder that you see things that are very easy in the AKT, but you decide to fail it. So CKD is a cause of iron deficiency anemia. What else is a cause of iron deficiency anemia? Certain medications, my friends. And in medications are high yield. They are very broad. When we talk about anemias, think about megaloblastic anemias, phenytoin. It causes both megaloblastic anemias. It causes 2 types of anemias. So you need to know that phenytoin is a cause of megaloblastic anemia. Don't fail it in the exam. Whenever we're talking about anemias, many other medications can cause anemia. So if I were you, I would list 8 causes of anemia and I'll put medication as some of them. Well, you are seeing in pediatrics and you are saying, well, I don't know the causes of anemia in pediatrics. There are so many, my friends. Well, a patient that is having diarrhea and having anemia, how do you forget that amoebic dysentery can come with blood? Causes of bloody diarrhea, they cause anemia. What are you doing? Well, I wanted to talk about diarrhea today. I say if I talk about dysphagia, I talk about diarrhea on the same day, it may be too much. So I stopped there. I just said, let me just talk about only dysphagia. The next class, let's talk about Crohn's disease, ulcerative colitis. Let's talk about diarrhea. Let's talk about carcinoid tumor. Let's talk about some small topics alongside the big ones. Because it looks like if we do so many big topics, you enjoy the class, you forget. So let's do them in small lumps. I know time is going, but it's good to know these things. If today I can succeed in making sure you know at least out of the over 100 points we're painting here, if you know at least 50 points, is good for us. Well, I'm going to stop because of time. I'm going to do alcohol calculation. After that, I'm going to talk about vitamins. I'll stop there. There are a few other slides. I'm not going to do them. Go and consolidate on these points that we've learned today. So alcohol calculation will greet you. My friend, it will be your question one. And failing it in the AKT is tantamount to self-harm. Is wickedness to yourself. Smoking, I told all the candidates in the drill that if you fail smoking calculation in pack years, you are being wicked to yourself. That is the simplest question you will see in the AKT. Number of sticks times the number of years the patient have been smoking divided by 1,000. They are in all your question banks. How do you now fail it? If you check on the RCGP website, they've stipulated that candidates have been failing questions related to these things. So you know that this kind of question may pop up and you fail it. Why? In the same light, alcohol calculation can come out. And look at what I've done in my slide. My slide is not to teach you a topic on alcohol. I don't have that time. I just want to show you what candidates will see and make them fail. So you can see that my first point there is candidate fail because they don't check time period. I know you guys have seen these things before. Some of you are not new to GP training. The ones that are new to GP training, some of you have been seeing alcohol calculations in previous postings, in previous educational pursuits. So some of these things are not new to you. But what is new to you is how the AKT may present it. And that's why people fail. Always look at the time period, my friends. So I present to you this patient who has, so in the AKT, they will give you the strength and they will give you the amount, they will give you the meals, hopefully. If they don't give you, what I've done for you is I've put a slide that has everything. Learn it. Don't assume that they'll be very generous. Don't assume that they'll be very nice. I hope they will. Giving you, because all the questions, past questions I've seen, Canadian exams, USMLE, AKT past questions, they always give the strength. They always give the amount of meals. So I presume they won't be very wicked to not give you. But if they don't give you, know it. This is the story about knowing everything to go to the AKT. The AKT becomes scared of you. So I give you this picture of someone that is taking small shots of a particular drink. He's a 45-year-old man. He's taking small shots of spirit. And he has been taking 25 meals. He's taking 40% of it 4 times a day. So how do you calculate that? Well, once you've done your 25 times 40 and you've divided by your 1,000, what you need to do there is to ensure that you multiply by 4 times a day. So that's where, because they say 4 times. So each of those 25 is taking 4 times. So candidates do the calculation, they know the calculation, they forget to multiply by 4 and they fail it. At the end of that multiplying by 4, they think that's the answer. They pick the answer as 4 because when they do the multiplication, they got 1 times 4, which is 4, and they pick 4. In the answer, option A will be 1. That's 25 times 40% divided. Option B will be 4. That's when you multiply that by 4. But option C is the correct answer. They said a week. You must multiply it by 7. The answer will be 28 units. The answer will be 28 units. So I've just put that there. I've not calculated it. The answer is going to be on the next slide. I'm putting it there for someone to try and do that calculation. Look at the other one. So look at the bottlenecks. 275 meals. They put the strength, but they said twice a day. How do you not know that I'll multiply by 2 first? Then they say, how many units has she drank in the last 2 weeks? Some candidates don't even see this. They start to have myopia in the exam. You can't have CHOM in the exam. Somebody saying, what is CHOM? CHOM is closure angle glaucoma is hypermetropia. Open angle glaucoma is myopia. Don't fail it in the exam. So don't have myopia in the exam. Don't have presbycusis in there. Don't have. Yesterday, some people had color blindness and they couldn't see the colors in the exam. Don't have that. See the things very well. Open your eyes. His meals. Look at it there. The strength is there. Multiply your answer by 2, and then in 2 weeks, that's times 14. That's why candidates fail. And that's why I put it there, period. The times 14 is what they don't get. So you've got some things to work out there. If you are working it out, I'll show you the answer shortly. We'll look through it. Look at that again. 3.6%. They've refused to put the strength of 10 pints there. This is where you have to know the strength. That's why I say don't assume they'll always give you. What is 10 pints? What I mean, they've not put the amount in volume. What is 10 pints? What do I convert that to? Some candidates will be stranded. So I've put it on this slide. They are there. Go back and look at them. So how many units has she drank? That's where they are just stopping there. They've not asked you period in this one, so they've made that easy. Look at the woman that is drinking 12% of red wine and she's drinking 4 bottles. Don't fail it in the exam. What is 1 bottle of red wine? 750. 750 mils. If it's a class cup, it's 125 mils. Don't fail it in the exam. But the question is particularly asking how many units has she drank this month? So you know that there is for the month. It's not for just a day. So you have to now multiply it by the number of days in the month. So if you were doing the calculation, some of you are very fast. You guys have calculated it. So that's the answer to the first one. 25 times 40 divided by 1,000. The answer is 1 because 25 times 40 is 1,000. So 1,000 over 1,000 is 1 times 4 times 7. I hope nobody will fail it in the AKT. If you have tried the second one, you have attempted it, you got 42.35. Well done. That's the answer. If you have attempted the third one, 10 pints. A pint is 568. So it will be 5,680 because you multiply by the 10 pint times the strength 3.6 divided by 1,000, and whatever you get should be 20.45. If that was your answer, I think you are ready for the AKT. The same thing, if you do your other question like this, 750 times 4 divided by 12 times 4, whatever answer you get there, that will be your answer. So please check the period and check how much they drank. Sometimes they put 4 bottles. The candidate will not see the 4. They will do a very beautiful calculation. They fail it. So the 2 reasons why you fail, I started with the most important one is the period. But the second one is the amount of bottles, the amount of cups, the amount of pints. You can see that it plays a role. If you get that, smoking calculation, alcohol calculation is a thing of the past. Right. If you're having any problem with alcohol calculation, my friends, check this new slide I'm sending. Strength times volume in mils all over 1,000. That's the calculation. Look at the period. Look at the amount of bottles. 2, if they have not given you the measurement, look at what the measurements are. Look at what a small glass is. Look at what a large glass is. Look at what a standard glass is. A beer bottle is 330 mils, my friends. Use the UK one. Don't because you are drinking beer in another country, use the other country. They are not the same. So beer can, look at it. Beer bottle, look at it. Wine, look at it. Pint, look at it. Don't fail it. What of the strengths? Those are the strengths, my friends. So look at them. It doesn't take too long. If you want to find a way to remember this, it doesn't take too long. Just settle down. Look at them. Read around it, and that will be helpful. So there's a recommendation from NICE. Is the woman pregnant? Yes. If she's pregnant, 0 units of alcohol. Sorry about that. So a pregnant woman, 0 units of alcohol. She shouldn't drink any alcohol. That's the NICE guideline. Not 1%, not 2%. Is a no for a pregnant woman. In the past, women used to be different from men. They used to say women drink less units, men drink more units. Please, it's now 14 units per week for everybody. Anybody that is drinking up to 14 units, please spread it out over 3 days. So if you want to drink 14 units, why don't you drink 3 units on Monday, 3 units on Wednesday, 3 units or the remaining units on Saturday? It's better. Why? Because of the liver. It reduces the pressure and the tension on the liver.